Good afternoon, everybody. Health Choice Network and Alliance Chicago together in action. Got Vaxxed, where are we, and who is left? We have a great programming for you today, and so let's get started. We're actually going to celebrate this weekend, the 4th of July. So we would like you to participate with us in our word cloud. And so what would you like to look forward to this 4th of July? So get out your cell phone and type in the message line 22333, and then put in COVID-19 heroes, and you'll be able to join in to our word cloud for today. So it looks like someone's going to Sarasota for a vacation. Someone's going to have a barbecue, beach time, swimming, fireworks. So I'd like to hear from a few others of you. What are you going to do this 4th of July? Hopefully more than just a barbecue and vacation. So join in. We want to make sure that everyone is joining into our word cloud. So why don't we go ahead and get started with our webinar today. And we're going to advance the slides to show you our agenda for today. So we're going to have a word from our chief executive officers from both Alliance Chicago and Health Choice Network. Then we'll get some COVID-19 vaccination rates updates from one of our colleagues. And then we're honored to have NAC speak with us today about a national perspective on where are we with COVID vaccinations. And then most importantly, we want to hear from our health centers. We're going to hear from 4 phenomenal health centers doing great work across the country, all the way from the East Coast to Hawaii. We'll have a few closing remarks. So let's go ahead and get started. So first, we're going to hear from our colleague, Dr. Fred Rockman at Alliance Chicago. Fred is the CEO of Alliance in Chicago. So welcome, Fred. Great to see you and hear from you.
Thanks, Tim. Thanks a lot. And here you have an illustration of pre-COVID, post-COVID. So if you would advance the slides, just a couple of thoughts to share with you about what was in our minds when we met him around planning today's webinar. You know, yesterday I was really disappointed to see this headline about an outbreak here in Illinois amongst children who were infected by COVID, including at least one that was serious enough to need hospitalization, all traceable to lack of vaccination in that community. Next slide, please. So obviously we are really thrilled, like Tim started us off thinking about getting back to some semblance of normal, all thanks to progress we've made due to the vaccine. And this chart shows this sort of awesome rapid progress that we've made over a few months in vaccinating, much of it due to the efforts of people on this call. However, as you notice, this curve is plateauing. And unfortunately, the work is not getting easier, it's getting harder. Next slide, please. So the reward is clear. We see this clear graphic relationship between vaccination and decline in infection. And nonetheless, we know that there are substantial numbers of people in the country who still are not convinced. They still do not want to get vaccine, despite the fact that we're now out of the phase where vaccine supply was the limiting factor. It's now the willingness. Next slide, please. All of you are in very different realities. This has been true of the COVID experience all the way through. It's highly variable by geography. So we're really thrilled to bring everyone together to reflect on it based on the difference. And this chart is probably not even granular enough, right? This is down to local geographies, but if you drill down, there are local populations and subpopulations and communities where there may be important trends for us to be factoring in and tracking, and why it's so powerful that we, as community health centers that are focused at the community level, are undertaking this work. Next slide, please. So here you see the disparity data that we've been working on. And of course, we've been tracking and concerned about these disparities. And a few webinar or two ago, we talked a little bit about disparities in vaccinations. If you go to the next slide, here is some good news, partially or maybe largely due to some efforts of people on this call, is that if you look at the gap, the percentages that the various race ethnicities represent as percent of total population, you can see that people that are vaccinated are beginning now to mimic those percentages, showing that we are making substantial progress on disparities amongst vaccinations. So there are other issues and factors at play. You saw that slide dramatically illustrating the variability across the country in penetration of vaccine acceptance. So we're eager to have this time together on this call to be comparing notes and developing strategies. So I'm so energized and happy to be back on the call with all of you. That's it for me, Tim. Thank you. Turn it back to you.
Great. Thank you, Fred. We so appreciate your words and all the leadership that you've done over all the years, recently with COVID, but more than that. And now we're going to turn it over to Fred's partner, CEO of Health Choice Network, Alex Romeo. Alex.
Thank you, Fred. Thank you, Tim. Hope you can hear me okay. I like to focus on what the lessons we have learned. And I had the opportunity to spend some time with some of our health centers. And of course, thank you all for participating today. Thank you for all our speakers today. You are truly our healthcare heroes, and we are forever indebted to your work, sacrifice, and passion. I spent a little time with the European Observation and Health Systems and Policy founder, Dr. Joseph Figueres, and he put it into the best sentence I've heard since the pandemic started. How do we prepare for the future? How do we prepare for future pandemics and future emergencies? And he says, the most important lesson we've learned as far as innovation goes, because you know I'm a techie, is that the human contact, the fact that it was disrupted, the ability for us as humans to stay connected, was the most expensive and scarce disruptor across this pandemic. And the idea that organizations and countries across the country are reporting very much high compliance and success with vaccinations in those countries that have a high ratio of physicians and nurses working together. So if you look at what the WHO is reporting, it's very interesting to me to see countries like Denmark and others that are showing that they have a high concentration of primary care physicians per capita and a high concentration of nurses per capita, are showing the highest success as far as vaccination and education goes, versus the countries that either have low primary care physicians or low nursing needs. So no secret there, but it's amazing that now we're tracking this data when our physicians have been telling us this all along. I also find it interesting, one of our colleagues from the American Hospital Association, they're in Fred's backyard in Illinois for the Center of Innovation, Lindsay Dunn, reported that some of the disruptors and what we're finding as innovation is primary care is now extremely attractive to many. We have all these risk models that are being developed, not only because of the pandemic, but the fact that we have all these disruptors joining us in primary care. And building an integrated view is going to be the differentiator of the future, and making sure that we can address these type of pandemics and all these type of crises that we suffer from on a daily basis in our communities. And how can we make it more affordable? But you think that telehealth has made it more affordable. As a matter of fact, the managed care value-based services companies are actually saying just because we're making it more accessible doesn't mean the spending less on healthcare. So with that being said, if you look at the disruptors and who's moving into our business, we're seeing that what remains the same is the enhancement of patient experience via telehealth, via wearable technology, via the fact that we have remote monitoring and really put turbo onto that, and we've actually expanded our reach there, and that we're increasing safety and the quality care of outcomes while we're driving some efficiencies. But what hasn't changed is the fact that we have this opportunity within our grasp to partner with our hospital partners, with our county officials, and making sure that we're better prepared for the next time this happens. And we're still not out of the pandemic. We still have a long ways to go as far as some areas, as Fred pointed out on the map, for both vaccination and education. So if you look at what the pandemic impact and what the strategies have changed, it's been very interesting. Providers of care, specifically primary care providers, have had initiatives that have slowed down. We now have long-term care outcomes that we were working on for so many years in preventative outcomes and social determinants of health have really taken a hit as our patients have moved away, and now it's our job to bring them back into a safe care environment. And vaccinating of communities, not just the COVID vaccine, but just vaccines in general. And so if you look at what the disruptors like Amazon, Walmart, and CVS are focusing on, they're focusing on the fact that we're going to be shifting from the pandemic and going into advancing their core health strategies. And that's important for us to know as we bring our patients back. Walgreens is investing $1 billion this year in primary care with their acquisition of VillageMD. As a matter of fact, they plan to have a VillageMD in each of their Walgreens facilities right next door. It actually even looks like a separate part of the building with even a separate color combination. And they expect to advance their telehealth strategy 24/7, including in-home visits. CVS is going to add 1,500 new healthcare hubs, which is doubling their healthcare hubs. They now have a mental health pilot expanding, and they're venturing out into focusing on access and affordability. Obviously, as a retail organization, they want to keep their patients inside their retail stores as long as possible, but they see the opportunity that they are as a disruptor. If you look at what Amazon is doing, Amazon has just expanded their Amazon Care for All, which was their term that they used for all their Amazon employees. They are now looking at Amazon pharmacies to adding convenience and accessibilities, and they're expanding their investment in-home and point-of-care diagnostics. And then lastly, Walmart, even though they've had this pilot going on, which they expanded in regards to bringing a health center like inside their actual retail stores, they're adding 4,000, I said that again, 4,000 Walmart Health Center supercenters by 2029. And their acquisition of the new telehealth provider, MeMD, means that they have a different approach. They realize that retail brick and mortar may not be the best approach, but they're still adding 4,000 healthcare supercenters by 2029. We only have 1,400 health centers funded. So we understand that these disruptors are moving into our facilities. So I'm excited about where we're going. I'm excited about the innovation that our partnership with the Alliance Chicago and HCN and all our health centers across the country are developing. And with that, I'm going to hand it back over to Tim.
Great. Thank you, Alex. So appreciate those words and the perspective that you give, and also the perspective that Dr. Rockman gives. So thank you. So both Health Choice Network and Alliance Chicago have been working together for a couple of things on COVID. Three things actually: to understand factors and underlying trends, to share perspectives and apply those perspectives and those approaches, and then three, to identify common issues and priorities, and then to address those at scale. So Health Choice Network and Alliance Chicago throughout this whole pandemic have been working together, hopefully to have some part in solving the solution with COVID-19. So we're going to move on, and I think we're going to have a first question here. So hopefully you can participate in our interactive poll. And again, you're going to get out your cell phone, and we're going to ask you to put in 22333, then COVID-19 heroes, and you'll be able to join the poll. And our poll question today is, what is your health center planning to spend the American Rescue Plan funding on? And here could be multiple answers. So you have two ways to answer that after you log into the poll on your cell phone. So put in 22333 in the to line. In the message line, put in COVID-19 heroes, and then you're get a response back to say you're in the poll. And if you want to answer one of them, that's great. You can put in more than one. You can just put A, send, B, send, C, send, or you can put A, comma, C, comma, D, comma, as many as you are, for what is your health center planning to spend the American Rescue Plan funding on? So why don't we go ahead and see what responses we have here. So great participation in our first poll here, and you'll see the numbers moving back and forth, just like the New York mayor's race today. It's going up and down. We are only doing one poll here. We're not doing multiple rounds of polling. So you have one opportunity to vote, but you can vote multiple times. So it looks here like we have a tie for both A and E. So COVID-19 vaccination capacity, so people spending the American Rescue Plan funding on that, and also infrastructure. So that's great, and it looks like we're getting a little more movement here. Some people are coming in some last-minute responses here. So it looks like, again, vaccination capacity is the number one, and then number 2 and 3 is E with infrastructure, and then also maintaining and increasing capacity. So great job. Thank you for participating in our first poll about the American Rescue Plan and what your health center is planning on spending that funding on. So now we're going to turn into our first speaker, who is one of our colleagues at Alliance Chicago, Shelley Sital. And Shelley is going to talk with us about the vaccination rate updates that she has been talking to us about throughout this pandemic. So Shelley, take it away.
Thank you. Go ahead and go to the next slide, please. So I just wanted to start off, I think many of you are probably aware, but just a brief update that as of June 28th, so just a couple days ago now, we're moving on up with the numbers. Unfortunately, the Biden administration had a goal set of reaching a 70% of individuals with at least one dose by July 4th. So we're going to be a little bit short of that, unfortunately, but that number has gone up in the last few days. So making good progress. The one thing I wanted to note here that I think is probably on a lot of minds is we are doing really well with the 12 and up category now. And so just a reminder to all to keep pushing on that, get those folks in. The key thing to note here too is that the CDC did update their guidance so that you can do co-administration. So get those young people scheduled for their regular vaccines and also get them in for their COVID vaccine at the same time. Just the only recommendation that's been made is that you try to either do it in a different location on the arm or if possible, a completely different arm or other location. Next slide, please. So just building off of what Fred was sharing earlier, just wanted to highlight here that you see the total doses administered reported across the country. We see the same sort of reflection here with the folks that indicated that they're hesitant. You also see here the darkest colors are the ones that have the highest doses administered, and then the lightest being those who have the lowest number of doses administered. So direct reflection of what Fred shared before, that vaccine hesitancy. Next slide here. Wonderful. So just also wanted to highlight, I know a lot of you have been struggling with sort of which vaccine to vaccinate with and having the capacity, but we do see overall across the country that Pfizer has been the leader in terms of vaccine administration, and we continue to see both Pfizer and Moderna are the two that have released data that is most effective for some of the variants, which I will talk about momentarily. Next slide, please. So again, just wanted to highlight, this is the 2-dose series, seeing that, again, a majority of folks are hopefully going back for their second dose. We see that 81 million people have completed both doses. So good sign there. And I do want to also highlight for those of you that may notice here at the bottom, it says unknown 2-dose, 69,000. So we are finding, and I'm just identifying this for folks that are at community health centers, that people are accidentally marking AstraZeneca or other vaccines when they report their COVID vaccines. So just a note to you to maybe highlight that with your staff, to ask folks to be careful and double check, because the state registries are maybe not always catching that detail. So just a comment there. Next slide, please. And I just wanted to highlight too, we do definitely see a direct correlation with when we started to really heavily be able to vaccinate and the reduction in the number of daily COVID cases, which is obviously a great sign that, as Fred mentioned, we are seeing a little bit of a plateau here. I know it's a bit small in this visual, but towards that part, it is kind of evening out, but kind of staying at that level. And I'll highlight in just a moment sort of where that's going as well. Next slide, please. And again, just kind of nationally and internationally looking. So we see here the global cumulative cases. This is what's reported by the WHO. We see that the highest incidence is, of course, in the US, and then we're seeing the higher incidences in South America as well, and in Europe. And this data is through June 27, so a few days ago as well. Next slide, please. So just to highlight for everyone, if you may or may not know of all the different variants, so the ones that are obviously the most common that we're seeing the most of as of December 2020 is what's referred to as the Alpha variant. So it's the one that was identified in the UK. And then the Beta variant showed up in January. That's the one that came from South Africa, as well as the Gamma, which we've seen less of, but that was the one that was first identified in Japan by travelers from Brazil. So it actually came from Brazil. I want to note too, the other one that's becoming more prevalent we saw in February was actually detected in California. So we do know that some variants are coming from the US now as well, and that was detected in February of 2021, so just a few months ago. And then, of course, the one that's on everyone's minds is the Delta variant, and that one was first detected here in March 2021. Next slide, please. So I just want to briefly highlight here, so the variant that's on everyone's minds, the Delta variant, we're seeing the highest incidence actually right now, and this data is all the way through June 5th, so it gets updated over a 4-week period, so the next update will be actually next week, where we see that Missouri surprisingly actually, or maybe unsurprisingly, has the highest rate of the Delta variant. And then we're seeing, for Illinois, I know many of you are probably joining us from Chicago or from neighboring areas, it's at 3.9%, and then Florida is 2.3%. The other states that are, pretty high that are noted here are Colorado, Arizona. And again, if we use that map of vaccine hesitancy and where we see doses delivered, we find that these areas that are increasing in numbers are places where people either only have one dose of the vaccine or have not been vaccinated. So just wanted to note that we have not had any reported cases of the Delta variant in Oregon, even as of recent, not on this, obviously, as well as Virginia, I believe, is very low, and West Virginia. So, of course, there may be variants that are showing up there that haven't been documented, but just wanted to note for you all sort of the states that are more prevalent or noticeable for those of you coming from those states. Next slide, please. So I wanted to close out today just as a reminder for those of you that may not have joined us previously, we did conduct a survey that was concluded right before our previous webinar. And I wanted to highlight the top 3 concerns that we continue to see among staff in terms of getting vaccinated were side effects, safety and effectiveness, and the feeling that the approval process was rushed. So now Moderna and Pfizer are being reviewed for full approval, and so hopefully that'll help influence some individuals that may still have been hesitant because they felt the process was rushed and the vaccines did not have the full approval of the FDA. And the most important thing I want to note here for you all is that the individuals that responded to the survey, and we had a very large number of people, and I'll show you that on the next slide in a moment, they all more or less said that the reasons that they changed their minds in order to actually then get the vaccine was getting guidance from a health professional that was at their health center, or getting guidance from their employers, and more also importantly, getting guidance from their local health departments or state health departments. So the moral of the story here is you all have a lot of influence. It's very important, especially if you're a provider, that you talk to your staff or you talk to your patients, because you really do have a lot of power in guiding their decision making to get vaccinated. Next slide, please. So last but not least, just a quick summary. We had 766 respondents to this particular survey. And again, this was only given to staff, but it was any staff at the health center. We had a relatively representative sample across both Alliance Chicago's health centers as well as Health Choice Network. But we did see that a majority of respondents were females. And unfortunately, this time around, majority of the respondents were white identifying, unlike the previous survey, which had a little bit more of a mix of race ethnicity. I believe that's my last slide, so I will hand it back over to Tim. Any questions you want to share, please feel free to put them in the chat.
Great, Shelley. Great work, and we really appreciate all the efforts that you put together on this survey and more, so thank you. So next, we're going to turn to our national partners at NAC, and Dr. Skapik is going to talk with us about some of the data and information that NAC is seeing. So Dr. Skapik, are you with us?
Can you see me?
Yes, Julia. Welcome.
Hi, thank you so much for having me. It's a pleasure to speak to all of you, and thank you for all the work that you're doing on the front lines, seeing patients and fighting the pandemic. I should say I am a primary care provider at Neighborhood Health of Virginia, 20% of my time. So I'm a little bit right there with you, but thank you for all that you've done, and let's go ahead and move through my slides. Hopefully I'm not being too technical. Might skip over some stuff if I feel that I am. So here's our COVID-19 update. This is going to specifically focus on what we've done in sort of the data and informatics space. Next slide. Many of you are probably familiar with NAC's mission. I'll mention again that it's our 50th anniversary this year. And again, thanks to all that you do out in the community. Next slide. So I just wanted to stop briefly and remind folks, what is informatics? So I think of informatics as sort of a triangle, right? It's the intersection of the process of providing care and of people interacting with the care processes as well as the technology. And I always put the people as the biggest cog in the machine, because if we don't understand where people are coming from, how they do their work, what their preferences are, and how they think, then the technology and the processes can't support them. And it should be that the process and the technology is driven by the people and not the other way around. I'm sure many of you feel that your EHR is not driven by your requirements, and I will leave that for another conversation. Next slide. So I'm here to talk about the CDC-funded COVID-19 multi-state data quality improvement effort. In year one of this project, and we have been refunded for a second year, we had 6 partners that were linked to individual states. Those are those in the dark blue. Obviously, Health Choice Network and Alliance Chicago are 2 of our biggest partners, but the health centers working with all 6 of our partners expand across the light blue states. The goal of the multi-state project was to build infrastructure for public health, informatics, and data across the nation and across health centers. And in that project, we collaborated with partners all over the country to support using our existing data and systems to try and reuse that information to help inform the public health effort. And one of the principles of this project was, unlike maybe some public health efforts that have happened during previous public health crises, we should build something that's enduring and can be used for many purposes, and that maybe the next time, you know, God forbid that there is a crisis, we can turn this infrastructure on and start to use it in real time to help the response. Next slide. So for this project, we sort of took our arms broadly around the COVID-19 use case for health centers, because we know health centers are involved in all aspects of the public health response and the clinical response. So they do screening and testing, you follow up with patients and do case management for cases. We know that many organizations that are health centers are involved in contract tracing, regardless of whether or not they're getting paid to do that. You're required to do all this mandated reporting, and you also, of course, as our partners have already shown, do lovely analytics to support the point of care. The timeline for year one is shown here, so we're actually in the closeout process of year one and getting ready to launch year two. And our goals are really to understand how COVID-19 affects the health center performance and also patients and health disparities, and try to understand how we could use that data to inform better responses next time. Next slide. So our data strategy for the data infrastructure we built and for this project was to look at data at the patient level so that we could roll it up to other levels of analysis. So NAC basically takes data from partner organizations that is de-identified, and we use it to look at different levels of analysis. Can you go to the next slide? So here are some of the questions we wanted to answer at each level, right? We want to understand COVID-19 risk. We know that COVID tends to spread in households. We can, to some extent, get that data from our partners, although we're not at this point gathering address information, of course. Facility level data can help us understand sort of how the very local response is happening. And then looking across communities and populations at those health disparities and the differential spread of the disease in different areas. Next slide. So in order to do this, we started by building a COVID-19 data dictionary based on some of the measures that we wanted to extract. We included, the impact of social determinants of health. So right from the start, we sort of wanted to look at whether or not having social needs is a predictor of COVID-19. Much data suggests that. And understanding about what the outcomes are like for patients. And we reused existing data for these definitions to minimize the level of effort in reusing the data that comes out of real clinical systems. So for demographics, we aligned to UDS data. For COVID-19 diagnoses, we used ICD-10-CM codes. A lot of the code sets we used were actually developed by the COVID-19 Interoperability Alliance. They have some good material available publicly. We also looked at vaccinations and labs, and I'll talk about that in a second. Next slide. So we use a terminology tool from Clinical Architecture, which is a terminology vendor, and this is a place where we store code sets for the COVID-19 data dictionary, and people can go in and access that. And I'll talk at the end about how people have started to use the tool to do mapping from their own local systems. Next slide. So in order, though, to actually aggregate this data, we had to build a secure public health informatics infrastructure, and we lovingly call it Cosmos. Cosmos has three primary qualities we want to impart to it: flexibility, the ability to accommodate data from any source as well as any clinical or operational domain; scalability, obviously data gets big very fast in healthcare, so we have to be relatively fast in terms of processing, but also be able to manage large data. And manageability really sort of speaks to, can people understand it? Can people understand what we're doing with it, how to use it, etc. Next slide. This is sort of a schematic of the architecture of our data. Data comes from the original sources. It gets passed through a mapping to the data dictionary, and we'll talk about the next way of approaching that at the end. You can pass it through an API to us, or you can put it in a data staging environment. It goes into the data lake, and then we use a bunch of tools to clean that. And the data that passes the gold standard test, I suppose you'll say, gets promoted into these data marts, which is where we'll do the data analyses that you'll see coming up. Go ahead to the next slide. And this is our SciMedical data tool. You can go ahead and skip forward. We try to use standard terminologies and ontologies wherever we can. We know that not all local data does use sort of a publicly available set, and so where we can, we provide mappings. Next slide. And this is sort of a view of the data flow I was just talking about. You can skip to the next slide. This is where I got a little overly technical. And we do try to normalize data in different form and manner. So not only can we take it out of an EHR, but we can pull it from other potential data sources, including a plain old spreadsheet. Next slide. So I'm going to show hot off the presses data from our multi-state strategy as of the 28th. And this contains data from 5 of our partners, actually. And the 6 data partners been having some issues in getting their data cleaned up, and so we were included basically only the data that's been cleaned so far. HCN and Alliance Chicago are 2 of our biggest contributors to that data set, so thanks to all of you who have contributed data that have helped to inform this effort. Right now, we have somewhere upwards of 1 million patients in the data set, which is somewhat between 1% and 3% of the patients in the health center population. Next slide. And one of the goals of the project is also to provide feedback to our partners. So these are just patients and encounter data, but we've been working on creating automated dashboards to provide that feedback back to our individual partners and help them compare where they're at compared to sort of the larger FQHC population. Next slide. So here's where it starts to get a little interesting. So the light blue is the exposed patients, the dark blue is suspected COVID cases, and the orange are diagnosed formally. Of course, not surprisingly, this map sort of matches the pattern that we saw sort of nationally in the pandemic, where there was an initial spike over early in the pandemic, and then of course another spike later in the fall to winter. And if you look cumulatively over time, it looks like we have, somewhere of 500,000 maybe patients who had a confirmed diagnosis of COVID, and over 50,000 patients with a confirmed diagnosis, and over 100,000 patients that had a likely case. And we of course know that many likely cases don't get a confirmation with a test or anything because of either the high likelihood of the case or because they're lost to follow-up. Next slide, or because the testing window is closed. This is looking at encounters by month. We had a little tail of data, I think, here at the beginning. So really the data set starts at January 2020. And so you can see the different partners contributing data over that time period. Next slide. This is the pattern of testing that we saw. Again, the testing appropriately sort of mirrors what we've seen in the course of the cases that we've seen across the networks. Go ahead, next slide. The vast majority of tests done at health centers are PCR molecular tests, but we do have a chunk of antigen tests and antibody tests. I think that the number of antigen tests have actually started to creep back up as we're doing more sort of quick screening of patients who have either been vaccinated or patients who show up and then get confirmatory tests. Next slide. I can say that the data sets, when we talked to the partners at the beginning of this project, we said, what are the biggest challenges that you anticipate? And they said, well, normalization of data and data cleaning is very challenging. And so you just saw that we had sort of 3 categories of tests and one sort of not categorized. We actually received, I think, from our partners over 600 different tests reported, and some of those reported to the level of, here's a LOINC code or here's a specific test, and some of them were much more sort of, free texted kind of COVID tests, and so we do as much as we can to clean these up, but as all of you know, health data is very messy, and so we continue to see that. We hope that what we learned from this project can help us in the future to, advocate for health centers and health center partners to encourage our federal partners and state partners who are in the regulatory and public health space to make those definitions parsimonious and clean so that it's very easy to extract this data and we don't have that really messy tail. Vaccinations by month. So again, we captured influenza vaccine data because at the beginning of our project, we didn't know if and when a COVID vaccine would be available, but we wanted to sort of have partners be ready to track that. And of course, we see that the availability of the COVID vaccine is probably the biggest factor up to date here. I know that we are missing still some data for May, so that's probably why that number is significantly lower. But we are seeing this is as the health center response goes up and vaccines actually come physically into health centers in January and February and March, we see those numbers go up. So great work on everyone out there for getting shots in arms. Next slide. This mirrors, pretty well what we've seen nationally in terms of the distribution of the data. There are a large portion of our patient data that didn't have the manufacturer listed, but we know that most of those were Moderna and Pfizer because those were patients that had 2 vaccinations for the most part. Next slide. This is an example of sort of where we're moving with our infrastructure, is to sort of have these dashboards set up and allow partners to get in and take a look. And our data infrastructure is capable of providing health center extracts as well if health center identifiers are listed with patients. Right now, we were just looking at the partner level. Next slide. So I just want to talk a little bit about challenges with COVID-19 vaccination data. And I can tell you that NAC is involved right now in an effort to sort of document what these challenges are like and to turn that back around and try and advocate with our public health partners for significant improvements in the data infrastructure for vaccinations in the US. Of course, we aren't interested in doing that just for COVID-19, but obviously this being still an urgent issue is a good time to really try and make progress on it. As we know, each state has their own immunization information system, or IIS, and as a result, each state and even sometimes localities will have different requirements on how they would like to see reports about immunizations that have been given. But this is a major barrier to success. It leads to a lot of data inconsistency, and it probably is a non-value added approach to reporting. The good news is that the CDC has been investing, even before the pandemic started, in an approach that might allow us to report data once and then have it be binned into the correct state's IIS. NAC has pointed out to them very vigorously that that use case is the CDC's use case, and the use case for us as primary care providers is we need access and reports on that data as to who's been vaccinated. Otherwise, our clinics are just calling everyone who doesn't have a vaccine given by us, only to find out that half of those people got a vaccine elsewhere. And knowing that that data exists somewhere in a building in our state is a little frustrating, because obviously we have limited resources. We want to maximize our effectiveness. So what we're asking for from CDC and the states is for them to allow these sort of automatic reports, bulk queries, where we can say, tell me all of my patients who got the vaccine, and then we can sort of check our list, validate that a bunch of patients got the vaccine elsewhere, and really focus our energy on those people who are unvaccinated. We also know that many of you have gotten supply from many different organizations. We had health centers say, well, we've got the FEMA, and we've got the HRSA, and we've got the local health department. And that in itself is also, a significant barrier to the effective use of your resources. So the other thing we really want to push on is how do HRSA and other agencies align across themselves to make, again, these reporting requirements uniform, and the way maybe even that they distribute vaccinations similarly uniform, or at least connected. Next slide. I throw this in here because NAC is doing a PPRL Connect-a-thon, which is coming up. It's a way of automatically de-identifying your data so that you can share it with partners. If partners are using this same tool, then the system can actually say, well, you two may have this patient in common, and then you can use your normal pathway of sharing identified data to confirm that that's the same patient. So if anyone's particularly interested in that, feel free to contact me. Next slide. This is the next step for us, which is to allow organizations to do their own local maps using a terminology service. If you go to the next slide, I'll finish talking through this slide on the graphic. So basically, you would load in a sample file or even a real data file that's de-identified. The system will say, oh, I see this is Depo-Provera. I know that code. I know this is Depo-Provera. It's a member of this value set. And anything it doesn't recognize, like let's say you have a local thing that's called FQHCID, it doesn't know what that is. So it will say, what's FQHCID? And you can say, oh, it means health center identifier. You do this one time, and then every time your data comes into the system, it auto magically tells the database, oh, this means this, this means this, this means this, and you get much less of this sort of having to map or having to rename and change the files. Next slide. So, a huge thanks to all of you again. NAC is really working on, thank you to the CDC for a bunch of COVID expansion dollars, expanding our work in the area of addressing vaccine hesitancy, or NAC likes to call it building vaccine confidence, as well as looking at ways for us to reach mobile populations or populations with less direct access to care through public health ambassador strike teams. And we'll be probably putting out some more information on those efforts as time comes up. We really want to thank Alliance Chicago and Health Choice Network for participating in this work. I can say the CDC is constantly impressed by all of you, and they really would love still to hear more about what's going on the ground at health centers. So if you ever find anything you think the CDC would be interested in hearing about, please reach out to your network and they can reach out to us, and we'll get you folks on the horn together if that makes sense, or at least carry your messages up to the national level.
So great. Thank you, Dr. Skapik. We so appreciate that. We appreciate all the work that NAC is doing. And most importantly, though, we appreciate all the work that's being done by our care teams at the health centers. So again, thank you. So now let's hear from our true healthcare heroes, our health centers. The staff at all the health centers across the country have been working so diligently, not only for the past year and a half with COVID, but for 50 years in the community health center movement. So we're going to hear from 4 health centers. First, we're going to hear from a health center in Chicago, and we're going to hear from our colleague, Dr. LeMay at Erie Family Health Center. So take it away. We want to check your audio, I think, there, Dr. LeMay. Not yet.
Is that better? My apologies. So I'd like to start by talking a little bit about Erie Family Health Center's strategies in general in increasing vaccine uptake, and then focus a little bit on our adolescent population. I'll take the next slide, please. So I think, all of us found pretty quickly that Pfizer was the vaccine that started to be expanded to multiple age groups, down to 16 and then down to 12. And realizing that Pfizer is the one that can be used for the widest age range, we moved quickly to having Pfizer vaccine available at all of our sites. So we've got 13 health centers, 11 in the Chicago boundary and 2 in the suburbs. So that was one of the first steps that we took to increase vaccine uptake. And like many of you, initially when vaccine supply was limited, we really did limit our vaccines to our existing health center patients. But as soon as the supply started to go up, we started offering it to anyone who wanted it. And that really helped us to expand vaccine uptake as well. The other thing that we've been doing, especially recently, is absolutely offering COVID-19 vaccine, talking about it to every eligible human being who sets foot in our health centers, or sometimes, it's not even in our health center, but if someone mentions that, oh, my uncle's waiting in the car, oh, has he been vaccinated? Well, he could get it here today. So really just trying to offer it to everyone who comes through the door, regardless of whether they're a patient or not. And we all know that patients tend to struggle to take time off from work, take time away from school to come into our health center. And so for that reason, we quickly expanded to offering vaccine clinics in the evenings and on the weekends. We also partnered with hospitals and community organizations to actually have vaccine fairs outside the walls of our health center. So a series of vaccine fairs at a repurposed warehouse in a neighborhood that's been highly impacted by COVID-19, for example. And this really allowed us to broaden the reach of our vaccine efforts. Something that many of you are familiar with is just really always thinking about how can we do preventive health care at each visit, no matter what the stated purpose of the visit was. So for example, as a pediatrician, immunizations are a big part of the preventive care that I offer. And it really is part of Erie culture to address immunizations at every visit. And so we like to never miss an opportunity to vaccinate. So sure, you came in for a suture removal, but I see that you're missing your Tdap. Let's give you that. And we really have adopted that policy now towards COVID-19 vaccine. And this no wrong door policy kind of refers to the fact that patients can reach us in whatever manner works for them. So we did start to offer designated walk-in clinic hours for vaccine, but we actually accommodate walk-ins anytime. So if our health center doors are open and someone walks in wanting COVID vaccine, or someone accompanies a patient wanting COVID vaccine, we've accommodated them. And the other thing that has really expanded during this COVID-19 vaccination process is multiple methods of scheduling for our patients. So certainly they can call, but now there's a dedicated option on our phone tree for folks who are looking to schedule COVID vaccine. And in addition, through our website is a link for them to self-schedule online using ZocDoc. So just trying to make sure that we reach our patients we vaccinate our patients no matter which door they choose to approach us. Next slide, please. I'd like to spend a little time talking about how we improve vaccine confidence in adolescents. And one thing that we knew that going into once the Pfizer vaccine was approved for 12 and up is we have a lot of eligible patients now. How do we make them feel confident about the vaccine? And we know that healthcare providers are trusted messengers for our patients. And so who better to hear it from than your healthcare provider? And so it turns out that many Erie pediatricians have children who are adolescents and did get them vaccinated. And we thought, well, what better way than to tell of our own experience and why we chose to get our children vaccinated? So a team of Erie pediatricians teamed up with our marketing department and created an email that was a targeted email sent out to parents of teenagers who are patients at Erie. And the main message that you can kind of see reflected here on a screenshot of the email is that, yes, we are pediatricians, but we're parents first. And we evaluated this vaccine and we think that it is so important for our own children to get it. And here's why. And so that email went out and I happened to receive one because my child is an Erie patient. And so I saw exactly what it looked like. And it said from Dr. Zampino, Dr. Mendoza, et cetera. That was just a real quick way to catch the patient's eye. And then in the email, in addition to some photographs of Erie pediatricians with their children who are vaccinated, we also included some main points of information, essentially saying, hey, these are the reasons that the things that we evaluated and the reasons we chose to get our children vaccinated. And that focused on 4 main points. One was just the point that, these vaccines are safe and effective for kids. We actually included a sentence or two that specifically talked about Pfizer having a clinical trial that involved more than 2,000 participants ages 12 to 15, and how the vaccine ended up being 100% effective, which was better than expected. The second thing we mentioned here was that the vaccine was not rushed because there's a huge perception in all parts of the world, I think, that the vaccine was rushed and therefore it skipped some safety steps and is not safe. And we kind of really, in plain language, pointed out that this vaccine had people from all over the world working on it. And so that's how it was able to be developed so quickly. And there's no safety steps that have been skipped. And also reminding folks that the coronavirus is something that has been studied for, well over a decade, ever since the SARS outbreak back in 2003. The third point that we wanted to make is, yes, your child is going to have some side effects from the vaccine, but in general, the side effects are mild and they go away quickly. And reminding people that the fact that they have side effects is just a reflection of the body's immune response. We also offered appointments at various times so that people could schedule an appointment around some special event in their life if they didn't want to kind of be expecting vaccine side effects in the next day or two. And fourthly, the final point that we made, because this is a question that we certainly have gotten from families, well, why should somebody who's young and healthy get the vaccine? Why is it important for them? And so we made a special point in this targeted email about how we know that in the beginning we didn't see as many young people getting sick, but now we have new variants that are more contagious. We also have more data, and we're seeing that anyone of any age can get a severe case of COVID-19, and that includes folks who are young and healthy, like this, adolescent age group. And so these are the main points that we wanted to kind of bring up front to patients, even before sometimes having a conversation in the health center. And I saw a teenage patient the other day, and her mother expressed to me that she was really grateful for that email, and she was already on board and planning to get her child vaccinated. But she felt that extra kind of information from her child's pediatrician or team of pediatricians was helpful in reinforcing the topic that the vaccine is safe and effective. Some other specific things we've done related to adolescents is we offer and have made it, we offer this in the email, we offer it on our website. Parents can call and schedule a telehealth appointment with a pediatrician to discuss COVID-19 vaccination in particular if they would like to. And so that's something that they call, they leave a message, and they can get an appointment scheduled within 24 hours. And finally, patients of our teen center have access to something called live chat, which actually is not specific just to COVID-19 vaccine, but on weekday afternoons, our teen patients can use this chat mechanism and ask questions in general about health, but we also wanted to really focus it on COVID vaccine, where someone will, live chat with them. And that's another way just to meet people where they are and meet people in whatever way they would like to access health information and access COVID vaccine. And next slide, please. And finally, just wanted to point out kind of a special situation that we encountered. So we are honoring the state of Illinois rules around autonomous medical decision making, meaning pregnant teens who are parents themselves can consent for themselves for medical treatment, and that includes vaccination. And so this particularly came up prior to the Pfizer expansion down to age 12. At that time, the ACOG, the American College of Obstetrics and Gynecology, and AAP, the American Academy of Pediatrics, were giving guidance that for pregnant teenagers, they should be vaccinated with COVID-19 with any available vaccine. And at that point, they were saying if you have Moderna and you have a 16-year-old, that the recommendation is to vaccinate them. And so in those situations, our providers who take care of pregnant individuals were having that conversation with the teenager, and through informed consent, those teens were empowered to make their own decisions about COVID-19 vaccination. And that's it for me. Thank you all.
Great. Thank you, Danya. You guys are doing such phenomenal work at Erie, all the work that you're doing, your college at Erie, really a great job. So we appreciate your time today and your words. Thank you. So as we leave Chicago, we're going to go down to North Carolina, and we are going to hear from our colleagues, Tamara and Kevin, Dr. Priestley. So, Comwell partners, how are you guys?
We are doing well. Can you hear me okay?
Perfectly.
Good.
Take it away.
Good. We're just very happy to be here and appreciate the opportunity to share some of our experience and also learn from the other folks who are here. It's been a very productive afternoon for us so far. One of the things that we do at Comwell, one of the values that we do is the beginning of every meeting, we value people who have done particularly good work or who are really supporting the mission. And just wanted to say a special word of thanks to Tammy and to Tiffany Horn, who's another one of our nurses, for helping to get the data together and produce the slides for us. And also just to all the colleagues, because as much as everybody was sort of stunned by the whole pandemic when it first came along, we've also seen all our colleagues from all our offices how they have just really stepped up to the plate, so to speak, and gotten aboard and really supported everything that we've tried to do to get the testing first of all, and then the vaccines. And it's just been a heartwarming experience to be able to work with all the folks here. As a word of geography, which is one of my favorite topics, we are in Eastern North Carolina, and we start roughly just a little bit east of Raleigh and have a band of geography that runs down to where we are. We're in Charlotte, which is halfway between Wilmington and Myrtle Beach. So it's a nice vertical swath there of folks that we're able to take care of. And as mentioned just a minute ago, the 50th anniversary, our offices started back in 1971 as the Tri-County Community Health Center up and done where our corporate offices are, and primarily as a mission to some of the migrant farm workers and other underserved at that time has grown from there. Again, we appreciate being with you today. If I could go to the next slide, please. And this is of course the topic for today, where we are and what we have left. Just a few of the numbers that we have locally, starting mid-March of last year. The total testing that we've been able to do is listed there as 17,967. And to date, we've done 8,122 vaccines. A large part of this has been facilitated by our community outreach team. Tracy Faircloth is another RN supervisor that we have. And she and Sean Hicks, who's a relatively new recruit to our company, they have spearheaded the effort. And the entire team is made up with the complement that you see there, the total of 4 nursing providers, 4 of the day entry people, and 1 mobile unit driver who also helps out when they go out with the team as far as parking and giving out forms and all sorts of things like that. And again, it's not all these people go out at the same time all the time, but and it's been great to hear the reports and see the videos and pictures of what they've been doing out in the community and how they've been able to keep the effort going over the past few months. Next slide, please. One of the keys for us, and I think it's something that we all can find value in, and one of the ways that we've been blessed as our health centers here, is the relationships and the networking that we've been able to maintain. And a lot of these were in place to a great degree before the pandemic began. And again, everybody who's involved in each of these came together, and there was a lot of good discourse about how can we help, how can we work together, how can we get the maximum amount done without duplicating effort. And the first block there, the health departments, these are the counties that we are present in North Carolina, and we have been, again, very thankful for the relationships we've had with them, and they've helped out so much with efficiency in our project. The emergency management teams have been so valuable when we've gone out to do testing or vaccination out in the community. They have always been there helping to keep everybody moving through, and the traffic directed and parking taken care of, and just supporting us any way that we can. This area, we have a good relationship with the faith-based community. And again, so many people from that community stepped in and said, you know, we realize this is serious and it's going to require a lot of work. How can we help you? And they've provided advertisement, locales for us to do the vaccines in, opened the church campuses for us so that we could have the clinics there to do testing and vaccine. And it's been a really supportive thing as well. The folks from the Direct Relief Foundation have been so helpful and just done a lot of things that we, never imagined would come through. They have provided all sorts of supplies, protective equipment, even down to meal cards, the DoorDash meal cards that can be given out to people who are in need if they're coming through for a vaccine, and that's been a real good support. Our Board of Education in the various counties, again, have stepped up and helped to spread the word and get everybody involved. Our local NAACP, the chairman, Mr. Parker here, has, especially in Brunswick County, has been an invaluable resource, again, to get the word out, to support all our efforts, and to encourage people to get the vaccine. Getting back to our roots, the Farm Workers Association, each of those is administered per county, and they have worked with us. It's been just a wonderful meshing of things there so that we can get to the people that we need to. And Tammy and so many of her group have gone out on a regular basis, actually visiting the farms, seeing people where they are and when they're at work. So it's been a good thing that they don't in that situation don't even have to get off work and come into the clinics, and it's gotten a good response there. We have two councils that are present in our organization and in the community: the African American Advisory Council, also the Hispanic Advisory Council, and we are able to serve a good many from both of these communities. And through the leaders in councils, they've been able to get out information and help people get correct information about the testing and the vaccinations, and dispel any myths and rumors, and just keep the process going there as well. Next slide. Okay. Getting back to the direct relief folks, they have just really supported us in a lot of ways. The personal protective equipment, both before and after things were heated up with the pandemic, and this has been helpful for ministering in the community, also keeping our supplies in the clinics up to speed. They've offered other medications, things like Tylenol, NSAIDs, things that can be helpful. Snacks for the patients who are coming to the various clinics, emergency supplies that they might need, sharps containers that we can get rid of the used syringes with, and again the gift cards that can help them get some extra food there. Next, please. This is one of the photo share for one particular event. It was in our community. This is one of the middle schools, and the top slide, our director here in Charlotte, Ms. Balab, and Mr. Parker on her right, as well as the health department director, are there helping out. And you see also all those involved in the middle slide, the folks from the clinic, the National Guard, health departments, and emergency management, all working together to help get the job done. And a good many of our clinics have been drive-through. So I know this started with our local health department, but it's been for most of the time an efficient way to get people seen, do it safely as we can as far as preventing spread of potential virus, and also getting the vaccines done. One of the things I'd like to emphasize again, all the leaders that were helping out, like Mr. Parker, our own Pam Tripp, who's our Chief Encouragement Officer, all these folks have been going out and being present in the community and showing their support for the mission, giving out hand sanitizer, and just answering questions and taking care of parking, anything that they can do to help. And again, all the facilities, in this case the middle school, have been very helpful with providing venues to do this sort of thing. Next slide, please. Again, going back to the advisory council with the African American population, this has been very effective working with the community and with the faith-based community. And so we have various leaders in all of our service counties. We also have folks that are working with the Police Athletic and Activities League, which is, among other things, provides services for children after school so that they can have wholesome things to do after they finish with their school day. And they have actually been involved in producing some of the videos to help get the word out, help dispel any fears about so they're getting opportunities to do AV production, things that will be useful to them later on as well. One of the other things, particularly in one of the counties that's next door to our service area, they have started a Facebook campaign in talking about why I got vaccinated, and what they're doing is making videos to put on the Facebook, and so people can see those, and and again get confirmation that the vaccines are safe, that they're endorsed by people that they have respect for. Next, the partnership in the community with our mobile unit has been very very robust as well. When we get out in the community, we get support from all these different various agencies, and again, it's been a synergistic thing that has really helped us out. Next slide, please. If y'all could pardon me just for a moment.
I'll take the next slide, Dr. Presley. In our partnership with the North Carolina Farm Workers Association, the North Carolina Farm Workers Association actually went by county and formed groups. So we were able to be a part of every county that we serve and every group, and we meet every week. And they have a list of all the farm workers that are coming into North Carolina, H2A workers, that we are able to contact the farmers and get out to the farms and vaccinate the new workers that are coming in. And it allows us to go where they're at instead of trying to get them to come to our sites. If you'll go to the next slide, out of our total number of vaccines, 25% are H2A workers. This is actually out in the field. One of these areas is in a sweet potato house where the staff actually went to vaccinate the H2A workers, and then several other farms. And the girl in the pink that's in the middle, she actually grew up in that area. She knew a lot of the farm owners. So we were able to get in there really quick and vaccinate the farm workers. So far, we did do an interview from the car. Our supervisor, Tracy, and the director of nursing, Tiffany, had an interview from the Foundation for Health Leadership and Innovation, and did a phone interview from their phone in their vehicle and lost reception, had to drive down the farm to get reception back, and also featured in a magazine article from the North Carolina Farm Worker Health Program. Next slide, Dr. Presley, you can go on and take that.
Thank you, ma'am. Again, our advisory council in regards to the Hispanic community has been very helpful. We've been able to work with them and work with them to help get out the word and get the vaccines out to the farming community, and they've been helpful with giving out flyers and again promoting the vaccine as something that's safe and very beneficial. Next slide. And so as has been one of the major things today, completing the circle of who is left, still looking at the subsets of our population who are at higher risk, and trying especially to complete all the vaccinations there, particularly in the 65 and older group, which we serve a lot of in this area. People with the comorbid conditions like heart conditions and lung conditions, sickle cell, anything that affects the immune system, and the other diseases listed there. And so what we've been able to do is redouble our efforts using the electronic health record to go through and just make sure that we've contacted those that are eligible and who need the vaccine. And we are again using those efforts to try to reach all those who are still needing the vaccine in the community. And next slide, please. This was an interesting thing that Tiffany talked to me a little bit about as we were preparing this. The first portion of the year from January through mid-April, the number of vaccines was over 6,000. And then what happened between the two bars here was the difficulty with the single dose vaccine and the side effects from that. And it really sort of put a damper on for the next period of folks who were able to convince that the vaccine is safe and available. So, but I think that we're going to see a rapid recovery from that. And again, with thanks to the efforts of trusted leaders in the community who are using vehicles like social media to contact folks to get the word out, to validate the value and safety of the vaccine. That I think we're going to see a rebound and a resurgence of willingness to people to be vaccinated. I think that's our last slide, if I'm not mistaken. Again, we appreciate being with you today. We appreciate hearing all the other efforts that are going on, and particularly enjoyed the presentation about reaching the pediatric population. We're going to be concentrating on doing more of that in our neck of the woods too. But thank you again very much.
Well, thank you so much. You guys work as a team, pitching in where you have to and be flexible. And truly, Comwell is putting the word community back in Community Health Center. And Kevin, I think you got a little community in your own house there. It's great.
It is. We're blessed to have. We're now up to 4 grandchildren, and they come and go quite frequently.
It is one of the positive joys of COVID. We have become closer with our family and friends. So again, I want to thank you so much, Comwell team, and have a great day. We'll see you guys soon, hopefully.
Thank you.
And so next, we are going to leave North Carolina, and we're going to travel way west out to the big island of Hawaii and hear from our friends at West Hawaii Community Health Center. So Leanne and Chris, are you guys with us?
Good morning. Thanks for having us, Tim.
Great, take it away.
All right. So, I think we're all struggling with vaccine hesitancy and getting to people where they're at. I really love the work that Dr. Presley and Tamara are doing, getting to those farm workers. The numbers around that are incredible. So kudos to you guys. Let's go ahead and go to our next slide. Just for a little context, this is our service area. We service the entire west side of the big island of Hawaii. We've got 5 clinics, medical clinics, and we serve 18,000 patients over 90 miles. And I think people might not realize it if you don't live in Hawaii, but Hawaii is the most diverse state in the union. So within our rural setting, we have a lot of different communities that we're trying to target with different hurdles to overcome to get vaccinated, and I'll let my colleague Dr. Healy talk more about that later. Let's go to the next slide. So through the end of May, we administered about 9,400 doses. The vast majority of these went through our mass vaccine clinic. You can see in this photo, we were set up in a gym where every Friday we did hundreds of vaccines. We partnered with the National Guard and had some administrative support from another local primary care office. But as you can see, we had dozens of employees staffing these, and they were by walk-in only. So there was no appointments, which was kind of unique in our community. when it comes to these vast vaccine clinics, and that was kind of our way of helping our less organized patients get in and get a vaccine. So, while that was ongoing, we were doing daily vaccine appointments in one of our clinics. Really because of our mass vaccine operation, we were kind of able to blow through the Department of Health and CDC phases. And so with those vaccine appointments in our clinic, we were kind of able to address our more high-risk patients who weren't necessarily in a tier and able to get a vaccine elsewhere. And then finally, while this was all going on, we were doing targeted outreach clinics, similar to what Dr. Presley was just talking about. And as we've moved away from this mass vaccine clinic model, it's really given us the bandwidth to do more of these outreach clinics. Let's go to the next slide. So, again, similar to what we just saw from Dr. Presley and Tamara, vaccine demand has really kind of tapered off just as quickly as it came on. So these are just, a graph of how many doses we've put in arms over the last few months. And you can see that in May, it just dropped off substantially. And we were still doing our mass vaccine clinics in May. So, and then this data is a little bit old at this point, but it just shows that here on our island, 70% of the population 12 and up has initiated a vaccine. So we're a little bit ahead of those national numbers we heard about earlier. And I'd say that just like, we're hearing about all over the country, our unvaccinated groups are concentrated groups geographically. Let's go to the next slide. So, one of the things that I'm sure was not unique to us is that we had to overcome our own exhaustion when it comes to COVID activities and getting vaccines out. So all of our outreach clinics were happening outside of normal clinic hours, right? They were happening in the evening or on the weekends. And when you have dozens of staff that you're trying to get to come in on their day off, it was really taking its toll on our staff, and people were feeling burnt out. So something that we tried to transition to closer to the beginning of this year was having like a strike team model. So this is a photo of our newest clinic. It was under construction when the pandemic hit. So we were able to kind of align some short-term and long-term priorities and use some CARES Act money to fund the completion of one of the wings of this new clinic. The caveat being that we would use it exclusively for COVID activities. It was ready to go back in January, but we are on Hawaii Island time here. And so the local authorities kind of dragged their feet on giving us the permits to occupy it. So it really only opened up in May. But what this has allowed us to do is every day we can offer testing and vaccines at that clinic. And then we have a dedicated clinician that we hired just to staff that clinic. And we have dedicated support staff. And so, on a day-to-day basis, they can offer, these vaccines and testing, sick visits. But then when we have an outreach activity, we can flex their schedule so that, they can go out on a Saturday and do an outreach event and, not be burnt out by it because maybe, we'll give them a Monday off or something. So at this point, I'll turn it over to Dr. Healy to talk more about what that strike team's been up to.
Thank you, Chris. My audio okay? Wonderful.
Yeah.
Aloha everyone. Welcome. We're happy to be here and we appreciate the invite so that we can share all of the great activity going on in our community of Hawaii Island. As Chris shared, for context, we do care for literally half the island. We have an 80-mile range that we divide and conquer. We can go to the next slide, please. And along the thought of dividing and conquering with our many diverse groups, we're always being mindful of protocol in the sense of going through proper protocols and chains and channels of communication to reach our most vulnerable groups. Dr. Fred shared early on in this in today's session the high rates of positive cases found amongst the Native Hawaiian Pacific Island group. Well, on Hawaii Island, we have the highest percentage of Native Hawaiians living here, so that is of great concern to us and has been for many different reasons. Some of the photos shown here just portrays the outreach that we have done to Native Hawaiian Pacific Islander groups. Also, our next largest group can be found with the Kofa Nations, our Kofa community citizens residing here. Across the state, we have the second largest percentage, which is about 12,000 with Marshallese living on Hawaii Island, followed by Kosrae from the Federated States of Micronesia, about 2,000 members. So here we have our strike team in action. From the far left, we have our clinical team administering the Johnson & Johnson and Moderna at an affordable housing location called Uluvini. It's a location where people are in transition. And so while living there and residing there, they have access to a number of different social support services. Followed by a picture of our community health worker, Metu, in the pink and black hat. Part of my team, I'm blessed. I have a very talented group of community health workers from community. They're the eyes and ears. Metu is just one of 3 Marshallese leaders that serve as community health educators on my team. And our primary concern with our outreach is health access. Language is often a barrier, but through the help of our community health workers, we've been able to mitigate that and get access to care immediately, removing any barriers and gaps. Followed with the beautiful photo in the middle, our keiki. Keiki is the term for child in Hawaiian. We do outreach at all of our sites, affordable housing location sites. We include from keiki to kupuna. Kupuna is our elderly. So we often have access for keiki to healthy education opportunities and others. We include them wherever we are, we go to them. Followed by the last photo on the right, we have a community member from Marshall Islands receiving her first dose 1 of Moderna. So that was an extremely beautiful opportunity. We are going back for dose 2 on July 14th. Next slide, please. Farm outreach has also been an essential step, and all of our vulnerable groups. Early on, as COVID made its way around the world, we built, through our trusted relations in place, we built a strong outreach strategy working with our vulnerable groups. This particular farm outreach, you'll see on the left, the community health worker, Claudia, with the Frida on the face mask. Claudia leads our farm outreach, working with many of our migrant and seasonal farm workers. We have a number of different migrant patterns from Honduras, Guatemala, Michoacan, and others. And so Claudia has done a tremendous job, bilingual, and so that is essential to, again, removing the barriers and getting the messaging out. The picture on the right, the gentleman, you'll see him in a blue top and khaki colored pants. That's Father Noe. So I mentioned protocol. And specific to our Hispanic community, protocol is we go to the churches, the leadership at the church. Father Noe runs 2 masses, an 11 a.m. and 6 p.m. mass at St. Michael's Church here. This is an outreach at one of our local farms where we invited Father. Father said this was his first time going out into a farm on Hawaii Island, so we were blessed to have experienced that with Father Noe. Next slide, please. Yes, our elderly, our kupuna outreach. So as in most cultures and indigenous cultures, we revere our elders. Often they carry the wisdom and the secrets for moving ahead in life. And what we have here on the left is our team of community health workers. Through COVID, it forced us to really take a look at and become innovative in adding to our current outreach team. So with that, I was able to get approval for 2 specific roles, 2 community health advocate roles, one a kupuna advocate or elderly advocate, and the second is a community health worker COFA advocate. Frankie leads our COFA advocacy, but here at our kupuna outreach, we're able to provide blood pressure screenings in addition to blood glucose, in addition to following up on any of their needs pertaining to vaccines. We led our outreach across the state focusing on our kupuna, and so as a result of that, the health center was able to do a special population COVID vaccine for our Native Hawaiian group. One of our 5 health center locations is built on Hawaiian homestead lands. And so again, back to protocol, we reached out and worked with our kupuna and our kumu, our Hawaiian leaders there, in creating a maka'ala. Maka'ala is the term for being aware in Hawaiian, creating an awareness and education campaign on the importance of getting vaccinated. And so now with the strike force model, we have been able to continue the vaccination efforts as our associate medical director, soon to be medical director, Chris Peel has referenced. And we are grateful that because of the trusting relations we have in community, at state government, at federal government, county government, and local with our vulnerable groups, that we're able to continue the outreach efforts to our vulnerable groups that are still on the fence, but are leaning into the idea and accepting of the vaccination. I believe that concludes our presentation. So again, we just want to mahalo you all. Thank you so much for this opportunity. And please connect with us if ever you find yourself on Hawaii Island.
Great. I want to thank you so much, Chris and Dr. Healy. Not only do you tell your story so beautifully, you educate us and keep us connected to your island. We love it. And I'm sure anyone who has been to the Big Island, Hawaii, knows how beautiful it really is. And you can see that from your pictures and your faces. So thank you so much. And I'm sure if anyone out there is looking for a job, West Hawaii is hiring. So, send in your resume. All right, thank you guys. Little plug for you, Chris. All right, so now we are going to go from Hawaii and we're going to go to the big state of Wyoming. And Becky, how are you?
I am good.
All right.
Okay, I think I'm. Oh, I'm there.
Yes,
okay.
Take it away.
All right.
You are good.
Yeah, sorry, I wasn't quite. I didn't know what I was getting into when I said, "Oh, I'll say a few words." So I've learned a lot from watching everybody else. So thank you, everybody. And so here goes nothing. And I think that I'm just going to talk about what I hear the most about people that don't want to get the shot, or they have a lot of questions about getting the shot. Their biggest concern just is maybe it was developed too fast, they think, and they don't trust the government. It's beyond I can't think of why they would do that. But anyway, a lot of people still think it's a hoax. It's going to go away. I don't understand it, like I said, but oh my Lord, here we go. My husband was that way. I said, you are going to get a vaccine. I scheduled him for an appointment and he did show up. So that's a good sign. So I found that if I get kind of bossy with my patients and tell them, you're being silly, not doing this, after I've explained everything, usually they'll listen to me and come in. I've had a lot of patients show up for our clinics that say, now, when you tell me about this and did you get it and all that? And I'm like, yeah, I got it. We're all fine. We didn't turn into zombies. It didn't change our DNA and kind of that thing. But I'll tell you guys one thing. This has been the most difficult thing in the 30 years I've been a nurse, is dealing with COVID. Everything COVID. It's just some of my coworkers haven't got the vaccine, which is very frustrating. One of my coworkers, her husband passed from it. She still is anti-vax. And we were doing really gung-ho there for a while, and the blood clot thing with the Johnson & Johnson kind of hit the news, and then we kind of really slowed down. we haven't given that one here, so I keep telling my patients I don't want to say anything bad about Johnson & Johnson because it's a good vaccine, you know, and I told them what kind we give, and if they have questions, call, and, you know, try to stay positive, but reinforcing that this is a safe thing to do has been helping a lot. And I don't know, we're all kind of getting a little discouraged here because you can see Wyoming on that map is not looking too hot. I didn't send very many pictures here, but we're kind of light on the vaccine, so we just keep trying and trying. And the other thing that I really say when I'm really about to give up a patient, I'll say, you know, I'm a nurse. I'm not going to give you something that's going to hurt you. So, you know, if you have a good trust relationship with most of your patients, they'll listen to you. But I love all the things I heard about, like patients being able to schedule their self and gift cards. We haven't done that here. I don't know if we could, but I'm going to make some suggestions on that. And we haven't really done any mobile units. And so I think I've got a lot of good ideas about how we can maybe get this going even better. And these, yeah, sorry, those slides aren't exactly in order, but this was our, right there in the middle, we're Natrona County. We were at 30.86 and 24,316 given. And then 2 weeks, if you can find the one on 6/28 there for me, it shows we went up a little bit. I know that was, yeah, and then there's one more then where we got up to 32%. So, I mean, it's slow, it's hard work, and I don't know. I think we just have to keep doing what we're doing and convincing our patients to come in and get the vaccine, and hopefully things will get better because we sure can't change what they see on the news. I can't think of much else to say. A lot of stuff you guys covered already. I can tell you that when we first gave our first shot, we were all just about in tears when we finally gave our first vaccine in the clinic. It was just, it felt good. It felt like we're going to get somewhere. And I still tell the patients that to this day. It's like, come on, you guys, you got to keep with us here. You know, your sister did it, your aunt did it, your grandma did it. Come on, you can do it too. We're just trying everything we can to convince them to come in. So I think that, I don't know if I can add much more to it.
Well, Becky, we so appreciate your words because this has been challenging, and every community has had a different challenge. Yeah. And so I think many of us wanted to hear your story and Wyoming's story because there might be some different challenges there. And yeah. I think hopefully one of the things that I want you to let your colleagues, both in Casper and Laramie and Cheyenne, as part of a network, we're all in this together, and we will definitely want to make sure that as a network we're helping each other out. So I want to thank you for sharing your stories. It is difficult. The challenges in Wyoming are different than Hawaii, North Carolina, and Chicago.
Yeah.
So thank you. Right. Well, we will be talking soon, and thank you for sharing your story also. So we're going to conclude today's webinar, but I wanted to add just a couple of other items here. We're having something called Pitch to the Panel, which is for researchers to pitch ideas directly to researchers at the University of Miami. So please join that. You can send us an email if you'd like more information, or there's questions right on here. So the next slide is we want to make sure that everyone is aware that both Alliance Chicago and Health Choice Network together again, we're going to have our virtual educational conference this year. The registration is open. You can take out your phone and scan the QR code here and actually register right now. The date is October 12th through the 15th, so please save the date for that. Purpose, innovation, and partnership, always together. And then I think we want to thank our partners on the next slide. All of our webinar series has been brought to you by Alliance Chicago and Health Choice Network, but truly it's funding from our funder. On the next slide, HRSA is working with us. They are our partner. They are our government, our federal government. We want to thank them and thank everybody who has presented today, everyone who has presented at one of our COVID webinar series such as in the past. So hopefully everybody has a great day. Enjoy the 4th of July, and please be safe. Get vaccinated. Talk to you later. Bye.